This is SSN.
Story Studio Network.
I'm Tom Hoppe, and I'm your host of the Most Painful Podcast. In the last episode, we spoke to Lynn Terstra about her work and research on TBI and concussions. She talked about the different types of TBI and concussions and the types of treatment to help people. If you missed this episode, you can listen to it on our Spotify or Apple feed. With a high number of veterans and others suffering from chronic pain, what is the connection between pain and osteoarthritis? What can one do to treat or help people to have a better quality of life if they have osteoarthritis? To talk to us about it today, we are joined by Dr. Eugene Maida, who is with the Division of Physical Medicine and Rehabilitation and Anesthesia at McMaster University. Eugene, welcome to the show.
Thanks very much, Tom. Pleasure to be here.
Yeah, glad to have you on. So maybe I guess we'll just start. Just give us a short overview of OA and what it is and how it impacts people.
Yeah, absolutely. So unfortunately, in a sense, osteoarthritis is a very common issue for many of the Canadians. We know that up to 5 million people are living with osteoarthritis in Canada currently. And in the next 30 years, it's expected to increase to over 10 million. So quite prevalent. It's the third most common condition and disease state that we know of, with hypertension or high blood pressure, osteoporosis, and then osteoarthritis coming in at number 3. Although it can affect really all the joints of the body, we know that's most common. About 60% of people would experience it in the hip and the knee. So very common from that perspective. You know, one of the things as a physical medicine and rehab physician and we say physiatrist is we try to look at, you know, what effect does it have on patients' overall quality of life. And we know that, it has a significant impact on what we call the health-related quality of life and productivity of affected individuals. You know, there's almost $1,000 of lost income per year from people missing work. So up to 8 to 10 days that they can miss of work. Secondary to that, a number of limitations, both physical, mental, psychological, that can result as a result of their inability to perform many of these kind of activities of daily living that we talk about. A general sense, osteoarthritis, what is it, right? So everyone asks, what does that mean? Well, basically what it is that the protective cartilage, so the surrounding protecting cartilage of each bone, the cushions, the ends of bones, wears down over time. And, there's a number of different causes or reasons as to why that would occur. We do see that repetitive stress to the joint or irritation to specific joints. So we see, for example, post-injury. So a lot of my veterans that I see and as well as my professional athletes that I treat, we see that the post-injury of a particular area, there's 6 times increased risk of osteoarthritis to that particular area.
6 times?
6 times, yeah, absolutely.
That's a lot.
You know, we do see that those who have advanced age, so over 65, there's a significantly elevated prevalence. But, you know, as I mentioned, with some of our younger population who have repetitive stress and strain through the joints or injuries, you know, it can be seen in our younger populations in the mid to early 30s as well. And we do see that for a lot of the professional athletes that I do see. Genetics can play a role, bone deformities as well. So these things are potential causes or aspects of it. And unfortunately, there's no cure for osteoarthritis itself, but we do know that there are a lot of options and opportunities to mitigate around or to improve function and ideally quality of life for those suffering with osteoarthritis.
So we talk about wear and tear, and I guess on the professional athletes, we can see that. And so on the veteran side, we see, you know, the constant like heavy loads, rucksacks, that kind of thing over time, being beat around in an armored personnel carrier. So is that why there's a higher onset of that, even though there's no injury related to that? It's just more wear and tear early on in life?
Yeah, absolutely. So, I mean, oftentimes by the time that I get to see the veterans, it's because there's a particular area or aspect or potentially even injury that resulted. But yes, absolutely. The repetitive stress and strain, the forceful activities that they're involved with on a consistent basis definitely accumulate to that. Plus, you know, your active activities of daily living. I mean, many of the veterans that I see are very active outside of, you know, their core duties, right? So, you know, on top of what they already do, they're quite involved with other things that can accelerate that process as well.
So what's the connection now between OA and then pain or chronic pain? Is one come before the other or vice versa? Or, can someone have chronic pain somewhere else and then it's an onset after?
Yeah, absolutely. So, I mean, they could definitely be strongly interrelated with each other for sure. Is it the chicken or the egg, right? And you can definitely have other chronic pain conditions that are completely separate from osteoarthritis themselves. Oftentimes we'll see, and I tell my patients that you're kind of like a Jenga puzzle, right? So you pull a piece and the tower wobbles a little bit and you keep pulling a piece and it can only stand up for so long until, something becomes a little bit more prevalent or becomes a bit more apparent to them. So you can have a number of different concerns or issues or challenges that can present either even before and can be made even worse from osteoarthritis as a result of depending on the degree of arthritis that is there as well.
So if we're talking about chronic pain, we talk about with veterans, we talk a lot about identity and purpose after they leave. So
Hmm.
with OA, it's more of a structural thing versus like some other chronic pain is linked to depression. If you're more bummed out, you feel more hurt.
Hmm.
OA is not that. Or are there chemicals or that can impact OA if you're like depressed or you're
Yeah.
don't have purpose in life, that kind of thing or is it more of a structural injury?
Yeah, so I think the root cause of the underlying issue or concern can be it starts off as potentially a structural issue, but one of the things I tell my patients all the time is that if we look at just the structure, it's almost like we just put our blinders on and we forget everything else that occurs around you. So if you're not able to perform a particular activity, your mood and mental state take a significant impact. As I mentioned before, the toll that it takes on employment can have a significant impact on your mood, on your social life, on your interpersonal relationships with your family and your friends. All of these things can be quite cyclical. So, although there can be and there are many studies to indicate the inflammatory structural component or initiating component of it, they do have multiple outlying effects that can emanate from that. And really, if we're not addressing all of those things and we just put our blinders on and say that's it, and once you fix this, everything else should take care of itself, we're kind of missing the boat in a sense. So I guess it comes from our my chronic pain background as well too. We try to look at the more comprehensive, holistic approach, and that really does factor into treatment algorithms and plans and ways to optimize, really, at the end of the day, the patient's quality of life.
Because you talk about inflammation and from what I've been reading in some literature, I mean, sugar and those kind of things affect arthritis.
Hmm. Hmm.
So with OA, you're saying, so if we take like, I guess low back is probably a common one.
Yeah.
So if just keep it simple for people. So if the cartilage is worn out, so now it's bone on bone, that's my understanding.
Yes.
Is that the same as other arthritis that you have in hand joints and that where diet can impact that inflammation? Because it's really the cartilage that's gone, right? It's not. So what is causing the inflammation if it's bone to bone? We have the answer to this, but for a listening audience, what is that cause for that inflammation if it's just a structural thing like bone to bone?
Yeah, so really what it comes down to is when, as we mentioned, kind of those protective layers are damaged, whether that, as you mentioned, whether that be in the spine, hands, knees, hips, it causes consistent friction, irritation, and the inflammation can have a significant impact, leading to that ongoing pain generator that we see. So diet can definitely have a significant impact in regards to ensuring not only healthy living and quality of life, but also the nutrition to the area is appropriate. There's significant evidence indicating the Mediterranean diet or the DASH diet, which talks mostly about fruits, vegetables, whole grains, and showing that they're the greatest anti-inflammatory diets out there. So, there's quite a lot of evidence that would indicate that those are the recommended diets for sure. Obviously, we know that there is certain limitations in regards to degeneration, like you would expect when there is bone on bone at that standpoint. But providing that natural anti-inflammatory component to it as well is definitely a strong component of treatment for sure.
And so now when we talk about treatment,
Yeah,
I guess physical conditioning is an important component. Our muscles hold our structure up.
correct.
So now if someone is struggling with OA, what are some things that could be done? Like say they're in pain. So how do we
Yeah.
get them moving? How do we get, if I guess if they're athletic, it would be different, right? They're already used to that kind of working out routine, but someone who may not have been as active and now they're suffering with OA, what are some things that they could take away from this show today to help them?
Yeah, absolutely. And I think one of the main things that I think is important to stress is to, even if they're an athlete, if they're very active or not quite active, but they find something that is different from the norm, it's important to identify some of these initial symptoms. So those ones would be pain that is exceptional or out of proportion than what you'd otherwise expect. Stiffness, people will talk about often. My patients will say that specifically when waking up in the morning, they're very stiff and sore, and they're able to, throughout the course of the day, improve their activity levels. Reduced function, some tenderness over, say, for example, we're talking about the knee along the joints itself, losing flexibility, a grating sensation, or swelling. These are some common things that you would hear or see, and our patients often talk to us about that. When that happens, or when some of these symptoms come about, it's really important that we want to try to take away from today is providing this education of what to do next, right? And it's important that we go and seek further assistance either from our primary care physician, physiotherapist colleagues, occupational therapists who can give us this information in terms of how do we modify particular aspects of our day-to-day life. So when I talk to my patients about pain management as a whole, and specifically with osteoarthritis, I like to break it down into four compartments. So we call it like the four-pronged approach to care. So the first thing that I stress, which I think is really the most important, and one of those that we know has the best long-term outcomes for patients when they're able to self-engage with some of these active, as opposed to more passive interventions, is we call it the conservative approach. So one of the things that we talk about is weight management, right? So that's a first one of the things that comes to mind, and we know that with each pound of weight loss, there's up to a four-fold reduction in load bearing through a particular joint. So this is huge when we're talking about a knee or a hip specifically. So big important aspects to consider. Physical activity is another obviously very important and targeted aspect. We know that cardiovascular fitness and resistance, we kind of gauge, and Health Canada tells us about 150 minutes total per week, 30 minutes per day, 5 days a week is something that we look at. But also we call it neuromuscular control activities. So these are things which you may have heard about with Tai Chi, which does help to control specific activities and slow rhythmic movements. Low load exercise programs, so things like swimming or cycling, can be very helpful and are strongly encouraged. The next component of that is assisted devices. So those can be things like walking aids, canes, walking poles, shock absorbing shoes. So these are types of things which can definitely be utilized. And as well, if it get very common, you may see them with people walking around with knee braces, and they can have knee braces that provide some additional structural support and stability for different areas of where this arthritis may be kicking in. Then the next aspect, which again is still under this conservative approach, is joint protection. So it's the idea of understanding how to mitigate and work around your activities to make sure that you're not putting yourself at increased risk or increased harm. So avoiding particular activities that would otherwise bring on pain. So if it's for the knee, again, we would say squatting, kneeling, twisting, low seats. We can do other things where we can have raised toilet seats or raised bed to accommodate around these particular activities that you need to do, but maybe won't be as pain provoking if you make some modifications to it. So this is where our occupational therapists help us quite a lot. A lot of things too, as I hear from again, veterans and athletes, is that, I used to do this, I used to get it all done in one day, and that was it. I didn't have to space myself out or plan things around it. Well, when you have some underlying pain concern, whether that be osteoarthritis or anything else, we have to learn about things we call pacing, planning, and prioritizing our activities around our pain generators. So, our pain psychology colleagues, as well as physiotherapists, can definitely help us with these particular aspects to mitigate and work around our activities to ensure we can still complete them, but just not at the same level as we were before. So breaking them up into intervals can be quite helpful. Again, under the conservative approach as well, we know that self-management, so there's a number of studies that indicate that psychosocial interventions like cognitive behavioral therapy may help with the management of osteoarthritis and function. And then we have the kind of the basic things, which I think a lot of our patients and listeners probably use is ice to the affected areas, elevation, compression. These types of things can be quite helpful and can be done, in your home environment. So that's conservative, very big grouping. But at the same time, things that you can do typically in your own home setting, you may need some assistance with them, but mostly taking an active approach to your care moving forward.
And I guess too, the other thing too, as we age, is also muscle loss, right? And the impact
Yeah,
of that.
absolutely.
And then,
Absolutely.
you talk about weight loss. I know, well, I'm one of those people where I have a hard time putting on weight and putting on muscle, right? So I'm
Yep,
the
yep,
opposite end of it
yep,
too.
yep.
But that's all important to support the body as well as we age. So I guess, these kind of things from what I'm hearing you say too is, prevention is key. Is maybe if we're in the military or professional athletes or people who have hard jobs, is to start working out earlier in your life if you're not already doing that, to try to maintain muscle, maintain health, so that it's, as you get hit by this, you at least have something to kind of help you out, or to, what's the right word, have some reserves in the tank to help you through the.
Absolutely. Yeah, yeah. I talk to my patients a lot about having that supporting structure or scaffolding around the joint. So again, if we're referring to the knee, it's strengthening the muscles above and below the joint to provide that extra stability and support so we can offload some of the area or this repetitive stress and strain through the joint, is really key. And as you mentioned, a lot of our patients can find that strengthening those muscles and providing that extra stability and support is really all they need at times, especially in the early stages where we will not have to intervene to other aspects or other areas. And these are things that they can do either with some minimal guidance or even at home alone, right? So these are some huge important points.
So for people who are suffering with early onset of OA and they're doing all what you just talked about under the conservative regime, can they live into an older age without getting into the surgical interventions or walking aids and things like that?
Yeah, absolutely. And I think one of the most important things that we talk about, again, pain as a whole, but a specific osteoarthritic type pain, is we don't ever really treat an image. We treat a person. So we want to know what your function is like. And if you were able to perform your activities of daily living or your extracurricular activities and your function isn't significantly impaired, or you're able to modify it as with some of those tools and strategies that we talked about earlier, then absolutely, I mean, surgery would not be warranted or indicated. We typically leave surgery for the very last stage in some cases, and we would say that would be one of them. And once we've tried a number of other conservative roads and approaches, then we would consider or have the discussion in regards to that.
So I think I cut you off, but you started your first point there, and then, which was conservative, and then next one.
Yeah.
Yeah.
That's typically our first prong approach, as I mentioned, the conservative aspects. The second aspect is when we talk about medication management. So there are a number of different topical creams, anti-inflammatories that our patients will typically use and can be recommended. And then there's a whole set of oral medications that are also suggested and are approved through Health Canada in regards to using and helping to reduce the pain in which they're experiencing. So topical creams such as diclofenac, so it's an anti-inflammatory, can be purchased over the counter throughout Canada. And typically we ask our patients to apply it to the affected area, whether it be, again, in the fingers or the knee, and you can apply it 2 to 3 times a day. Typically, it needs to be put on those segmented intervals. I usually tell my patients breakfast, lunch, and dinner is quite helpful to remember those intervals to ensure that it's able to break through the layers of the skin and down to the affected area. There are a number of different compounded creams as well, which patients will use from time to time. They find them quite helpful. Typically, we would start off with the anti-inflammatory kinds. Tylenol, is something, again, it's our first line really recommended medication that can be used, purchased over the counter. And we talk about using reasonable doses would be maximum 3 grams a day of the Tylenol, but usually tell people, let's try once or twice a day, and you can always ramp up as necessary or as appropriate, are reasonable options. Oral anti-inflammatories, as well as the Aleve and some other medications that have anti-inflammatory properties, but also stomach protectors and coatings, can also be quite helpful. And then once we've tried those, there are a couple of other ones which are recommended, again, through Health Canada, but kind of our lower end ones in terms of on the line, where we use medications such as we call Cymbalta. And then there's also talk of certain times in certain situations where you would consider the use of opioids. But again, that wouldn't be something that we would jump to right away by any means.
Yeah, and you would be seeing a professional from there anyway.
Absolutely.
So you said you had 2 more points, right?
Yeah. So the third point are interventions or procedures. So oftentimes you'll hear patients say, "Well, I had a knee injection, I had cortisone, I had a steroid in my knee." So those are one component of it. There are a number of different injectables that can be done into the knee. The evidence would indicate that for both hip and knee osteoarthritis, corticosteroid can be effective in reducing pain and improving function for typically up to 3 months in total. But the evidence and the consensus in regards to how many and how frequent is a variable to an extent, but we want to try to use as many steroid sparing interventions as possible if we can. There are also lubricants or gels, we call them visco supplements, which basically cushion, support, and as well as provide that anti-inflammatory component. And there's some newer injectates that we're looking at in terms of platelet-rich plasma or PRP, which is often talked about and looked into, and some others that are not available in Canada, such as stem cells and so on, that are studied throughout the world. And then our last one, so our very last one is surgery. So, and then that's when we've kind of, exhausted, we've worked our way up the ladder. We've had an opportunity to try and see if we can try some of those conservative to more invasive approaches. And if need be, then we look into some of those additional aspects.
Yeah. So from what I'm hearing is, and I've heard this from other experts and been reading a bit about it on too, is to start early in life, stay fit, have a good lifestyle, be proactive with your health.
Absolutely.
Because it sounds like we're all going to get this. Some of us are going to get it earlier than, depending on our jobs, are going to get it earlier than anybody else. But that's kind of the number one thing I'm getting from this is be proactive with your health, stay strong, diet, the whole 9 yards, everything we hear about.
Right.
And I guess, we always hear professionals say, you got to exercise. But we're not getting like, well, what does that mean? What does that look like? Right. So I think those are that would probably be a talk for another day, but
yeah, absolutely. I mean, I think as well is to understand that there's many options to help address osteoarthritis as well. And some patients will say, well, I just need an injection. Well, maybe you don't, right? And maybe there are some other opportunities that we don't have to dive into this particular aspect, and we can achieve just as great a benefit from other opportunities that we mentioned before. And I think it's important for your listeners as well to note that there's a lot of great information available and easily free access. So, Arthritis Canada, arthritis.ca has tremendous amount of information, patient stories, things that you can work through in terms of medication management, as well as active conservative measures. And there's a number of great resources that are available, podcasts from experts there as well, too, that can talk about and kind of relay some of that information, which is excellent. And arthritisresearch.ca and the SOAR program, which is stopping osteoarthritis, particularly for knee. Great insight from a number of professionals there that can help to, really guide you and ensure that you have full access to all the education and the opportunities available to you.
So that's called SOAR.
Correct. Yeah.
Perfect.
Yeah.
And I guess the key is to keep moving, keep walking, do all that kind of thing.
Yeah, motion is lotion. That's the key that we always hear. So I think that's a really important one, and that's if you're able to do that, I think that's half the battle sometimes.
Well, we've run out of time. Love to talk.
Okay,
I'd love to talk more about it, honestly, because like you say, it's a huge topic. And the reason I thought about this too is, many veterans I spoke to are all talking about it. They're talking because they get it in an early age, a lot of them. And so we thought, well, let's dive into this a little bit. So, but I'm sure we could talk more about it. But for today, I think we're going to have to stop here.
No problem. Excellent.
Well, thanks for being on the show, Eugene. I really do appreciate it.
Thank you very much. Thanks.
And for our next show, we're going to be talking with Leroy Hoppe, who is a physiotherapist. He's going to talk about exercise and strengthening when someone suffers from chronic pain. So it's going to tie into what we're talking about today. So that'll be on our next episode. For feedback about the show or more information on chronic pain, you can visit our website, veteranschronicpain.ca. Follow us on Facebook and Twitter at Chronic Pain COE and on Instagram at chronicpain_COE. Once again, Eugene, thanks for being on the show.
Excellent. Thanks very much.
A lot of good knowledge, and I'm sure the audience will have a lot of takeaways from this discussion today. And everybody else, stay safe and keep the hope alive.
The most painful podcast.
is produced for the Chronic Pain Center of Excellence by Story Studio Network and Eye Contact Productions.